So, good evening, registrars. And Dr. Sally,
Yes, sir. Good
uh,
evening. Yeah.
good evening. Dr. Sudhir Kothari will be joining. Shall we start, or what is the information?
I'll just give him a call.
Dr. Sudhir Kothari has joined.
Hi.
Yeah. Good evening, Dr. Sudhir. So, shall we start?
Yes, start.
Yeah. Dr. Sally, I think you can start. These case presentations will be a regular affair hereafter. And as an examiner, I would like to tell few guidelines that whenever you present neurological history, there will be initially localization history followed by etiology history. And after that, you got past, personal, family histories, and any treatment history which you would like to know. Before you go on to the clinical examination, you should be able to tell what is the neurological syndrome as a functional diagnosis, and what are physiologically, what are the tracts involved, and anatomically, where is the location, and what could be the possible etiology. And after that, you will give your presentations of the clinical findings, and then you will verify where you stand after your hypothesis at the end of the history. So this is going to be the structure. Then there will be questions by Dr. Kothari and me in between. So let's go ahead. Dr. Sayali, please start.
Yes, sir. Yes. Good evening, everybody. This is a case of a 63-year-old man who is a resident of Pune, who has retired as a civil engineer in government. Informant is he himself. He's right-handed. He came with the chief complaints of difficulty in walking associated with lower limb weakness since last 5 months. That was his only chief complaint. The history of present illness goes like this. He was apparently all right 5 months back when he gradually started noticing that he had some difficulty while getting up from the squatting position. Once, while he was sitting in his farm on the ground, he needed some help to get up. Few instances like this happened, and then he also noticed that he had some difficulty in climbing the stairs over the next 2 months. Then a month later, he also started realizing that he's having difficulty while walking also. His knees used to give way and there was buckling of the knees and he had fallen once. All these complaints went on increasing gradually till the point now that he finds it difficult to stand and walk independently and has been using a walker since last 15 days. On inquiring further, he also mentioned that he had been having difficulty in wearing chappals since last 5-6 years, and chappals used to slip from his feet, and there was also slight difficulty in buttoning and unbuttoning. He also told that he had accidentally burnt his left foot 2 months back while bathing. Like he just opened the hot water tap and water fell on his foot, but he had no burning sensation. But later he had noticed that he had a bleb and a burn. But this was not his chief complaint. This history I got only on inquiring. And on inquiring further, he also told that 5 months back, when he started having walking difficulty, he had also noticed some vague burning pain over his genital areas. So this was his chief complaints and the history of present illness. Now I would like to mention the negative history. There was no history of weakness in the upper limbs, lifting heavy objects, doing overhead movements. There was no history of drooping of the eyelids, diplopia, slurred speech, dysphagia. There was no neck weakness. There was no difficulty in getting up from the supine position. There was no history of any abnormal movements. There was no history of any sensory loss over the face, trunk, any band-like or a girdle-like sensation. There were no paresthesias. There was no electric shock-like sensation. There was no back pain or radicular pain. There was no history of flexor spasms as well. There was no history of urinary urgency, frequency, retention, incontinence, constipation, abnormal sweating, palpitations, or postural giddiness. There was no history of seizures, altered sensorium, or memory loss. There was no diurnal variation in the symptoms. There was no history of fever, chronic cough, joint pain, swelling, rash, vomiting, or diarrhea. And also, there was no history of weight loss or reddish discoloration of the urine. past history was there was no history of similar complaints in the past. He was a known diabetic and hypertensive since last 30 years, and diabetes was somewhat not very well controlled. Family history was not significant.
Dr. Saili, I don't know, would one call diabetes and hypertension past history, or do you start by telling that this is a person who's whatever age, whose diabetic, hypertension, whose diabetes is not well controlled, and who has come with these complaints?
Usually they like to mention it in the past history, so I'm not sure, but sub examiners might prefer it telling it in the beginning.
See, I would by when you are suppose you are presenting a patient, is this important, or is it some unrelated past history? That is what I would decide by.
Okay.
Because see, the thing is that you want to, that is my lookout. I mean, that is my approach, that you want to steer the diagnosis towards what you are thinking. Now, if you think that the diabetes is not related, then it is fine the way you have presented it. But if you think that diabetes is at all related, then it is not the right way to present. What do you think, Dr. Gorthi? How would you
Yeah,
think?
actually, is a known case of diabetes for so many years and hypertension so many years presents with these complaints. It's how the comorbidities which are not related are mentioned. If they are related, as you say, yes, there's a flow of the thing. But one more important thing which I want to tell is in a no book, it is given as a negative history. See, it's a negative history is not entertained in the exam as a DM student. You give the positive things and then you say these are not there. Like you have identified muscle weakness is an immediate problem. You go on describing all the muscle weakness points in the body and then say what type of muscle weakness you are indicating. Is it a muscle origin or is it an upper motor neuron or lower motor neuron, and clear that issue. Then you go to the sensory, then you go to the other things. And if you think the difficulty in wearing chapels 5 to 6 years is a thing which you could elicit and you give importance to that, then I don't know, Sudhir, I think it should come in the presenting complaint and also onset insidious, course progressive slowly. That also two things which you mentioned before. So this is what is my observation so far.
Yeah, I would also agree. I mean, if you can go back, Dr. Saili, see, you start with, I know sometimes the patient doesn't give the history in the order in which it makes sense. Sometimes you have, but then once you have got all the history, when you present the patient, you don't present it the way you got the answers while getting the history. You have to create a whole story out of it.
That's correct. Sudhir, I think my teachers in AIMS also used to say that you have to develop a well-knit story after you got
Yes.
every information. And
Yes.
foolproof and start presenting in the way it should be presented. So in that context, I think we both are on the same lines, and Sally should start with 5 to 6 years difficulty in wearing chappals. Point one.
Yeah, so maybe you can say that the chief complaint the patient came for, go back. His chief complaint is difficulty walking and this last 5 months. But then you come in the next thing only you say, but after getting the history, it came to mind that he has, it's not, he was not all right 5 months back. Then you got the history. He said initially he was all right 5 years back, but he had this history of chappal slipping off. He does have diabetes and hypertension. He's not all right. So you have that will come earlier. That this is a diabetic and hypertensive who came with history of 5 months of difficulty in getting up, walking and getting up, whatever. And then then there itself you say that though he said 5 months, on eliciting detailed history, we got the history that this chappal thing, etc., all that comes earlier. Then even though he may not have told you, this is a very significant thing that he accidentally burned his foot and he underwent, he had to undergo amputation. So that has to be told.
That's correct. That's correct. And you have indicated that there is a problem in gait as well as getting a difficulty in getting from squatting position. So now you indicate what type of weakness you are indicating. Is there any wasting? Are there any fasciculations? Is there any stiffness in the legs? So that will give a clue to what type of weakness you are indicating to us. Okay. If there, though these points, like you examination wise, when you do motor system, you look for nutrition, then tone, power, involuntary movements. So similarly, you completely cover the motor system and say that, yes, this weakness I am characterizing, it is a LMN weakness or UMN weakness or muscle weakness with no doubt should be there in the examiner's mind that what you are indicating. Okay.
So
I
then should I
also think
mention in the history that there was, he noticed that there was some wasting in his limbs
Hmm.
uh, in the history itself, or that
he
will come in the examination?
No.
no, if he has noticed, only if he has noticed.
If he notices.
Okay.
If he
Right.
notices.
But see, Sally, what Dr. Gorthi and I both we are saying is that you cannot let the examiner's mind go back and forth. Is it UMN? Is it LMN? Is it UMN? Is it LMN? No, you have to steer them towards what is your final impression. And if something is not fitting in, if something is there, your final diagnosis is let. But he's giving a history of flexor spasm. You
Yes.
say that it doesn't mean I'm not saying you create a history to fit your narrative or your final thing,
That's
but
true.
you have those issues which are fitting in with your diagnosis. Otherwise, if I was an examiner, I'll get irritated. I'll see once you are telling me it's towards lower motor neuron, once you are saying it's upper motor neuron, I mean, what is going on? Then I start getting confused and I switch off after some time. That should not happen. The examiner should remain focused on the case. The diabetic who got who had some tingling numbness and chapel sleeping of 6 years back, who had whose sugars have not been controlled 2-3 months back. He once developed some weakness in the legs. 2-3 months back, he had to undergo amputation because of a wound. So whole thing has to come in that it happened, and not the way he disclosed. You understand? You say that initially he came only with this complaint, but detailed history elicited all these things, and then you come with all those things chronologically.
So sometimes now students have this problem that once they have taken history, they should not go back and verify the history. Yes, they should go back. And if you get more points, now your story should be built up in those lines. I think now if you have completed the presentation, would you like to summarize at this level what you feel? And before we go on to the analysis.
Yes, I'll
Yeah.
just
So
read the personal
three
history
lines,
and yeah.
if there's anything in personal history important, if not, just summarize in 3 lines or 4 lines. What is this patient? If you had to present in a very fast round, what would you tell?
So this was a 63-year-old male with long-standing diabetes and hypertension with the insidious onset of proximal weakness in both lower limbs, with underlying long-standing glove and stocking type of sensory loss in all 4 limbs and some paresthesias in the genital area without any autonomic involvement.
Okay. So is this proximal weakness it's not, I won't call it insidious because it's not going on for 5 years. It is something that has developed in last 2-3 months.
Yes.
He was walking
5
about
months.
2 months back,
Yeah.
and now he can't walk at all.
Yes.
So with a recent onset, really rapidly progressive proximal weakness, because when you're saying diabetes, I'm going to think, is this a diabetic neuropathy? So you want to tell what is not fitting in. This is a very rapidly developed proximal weakness or whatever weakness in the lower limbs. You think it's proximal, no? So you say who has developed a relatively rapid proximal weakness in the
There is
lower limbs.
also a sensation of burning pain or genitalia which you have to explain and bring into the story. What is that?
So that was a very vague history that when he started having difficulty in walking, around the same time roughly, he started feeling some burning sensation in the genital areas.
Are you going to give importance to that point, or you want to disregard and just forget about it and
So
give
I
it
would
as
like
well?
to give it importance
Then
in
you
the current
explain how it
scenario.
comes, how it comes. If I
So with the
ask,
proximal muscle weakness and the burning sensation in the genital area,
Hmm.
I could think of something going on in the lower part of the cord, like the lumbosacral area.
You have to be specific. Your spinal segment you are telling in the roots, or you are telling in the cauda equina. What is it you are telling in the genital area pain? Where is the localization? Is it S1, S2, S3,
It is S2, S3, S4, sir.
S2, S3, S4?
S4.
Okay. So you are thinking spinal cord pain, or is it a root pain, or is it nerve pain? What is that pain?
The spinal cord is less likely in this case
Then what is
because the
what is
patient
the
did not.
pain? Where is it coming from?
So it could be coming from any nerve or a root.
So is it a characteristic root pain? What are the characteristics of root pain? How will you describe
So
a
this
root
is not
pain?
characteristic of a root pain
How will you
because
describe a root pain?
root pain, it will usually radiate in the region of that dermatome, the root.
Yes. What else? What are the other characteristics? Yes, you are correct. Then what else? What are the characteristics of root pain? Their distribution in the dermatomal. What else? Are there any aggravating factors? Root pain?
What triggers the root pain?
Some sudden movements or bending can trigger
Suppose,
it.
suppose if I say all the maneuvers that increase intracranial pressure, do you think it helps you? Coughing, sneezing, somebody is, does it help you?
No, not exactly, but exercises, sudden.
Do you know the root is covered by a sleeve of subarachnoid space?
Yes, sir.
Then why not? So all the maneuvers which increase intracranial pressure will aggravate root pains, right?
And
Sneezing.
movement, which particular movement? You'll have to say what movement will make it worse. So
Yeah.
standing up, walking, if that aggravates, then you'll think it's a lumbar root pain. If it is cervical, you'll have to say that neck movements will aggravate it. So depending on what radiculopathy you are thinking of.
So if you think it's a neurogenic claudication, your history will be different, right? If you're walking, what is the distance, how it gets relieved on taking a rest or not. So we didn't characterize this pain very well in this region. So, and what weakness you think is muscle, neuromuscular junction, or root, or spinal cord? What is that?
So I think it is muscle because
Okay.
there's no diurnal variation, no
Mhm.
relation with exercises, and if it is an M junction, there is no extraocular involvement, no diplopia, no drooping of eyelids. So an M junction would be
How
less
will you
like.
explain this difficulty in wearing chappals 5 to 6 years and accidental burning?
So
You
this
are thinking, you are thinking of what? A syndrome which has got neuropathy also?
Yeah, it could be a
Do you think
syndrome, sir, or it could be like two different entities with a neuropathy and now something
So
related.
functional diagnosis, you are putting two things. One is neuropathy and another one is myopathy.
Yes, sir.
Huh? Or
Yes.
myeloneuropathy. What do you want to say? Is it myelin involved? Spinal cord is involved in this
No,
case?
sir. There are no features which were suggestive of involvement of the
Symmetrical
spinal cord.
illness, which is progressing. There's a buckling of the knee. How do you explain the knee buckling?
Knee buckling is usually due to the weak quadriceps,
Mm. And climbing stairs is because?
poor hip flexors and extensors.
Okay. No problem in the upper limbs. Has he got any difficulty in taking turns?
No,
Right.
he's using a walker, sir.
No,
So
in taking turns in the bed.
yeah, he has difficulty in taking turns
That
in the
means
bed
that,
also.
that has increased up to abdominal and trunk muscles, isn't it?
No, he doesn't have weakness in getting up from the supine position,
Hmm.
but definitely while moving his legs in the bed.
Has he got any difficulty in managing his head? Is there any
No neck weakness that I've mentioned, sir. There was no neck weakness.
is there any dysphagia, dysarthria, dysphonia type?
No bulbar symptoms.
Right. So physiologically, what do you think are involved? Is
So
it the
since there is muscle involvement as well as nerve involvement,
muscle and nerve both?
both.
Okay.
So I think it could be um,
Anatomically, what do you think? Where is the lesion? It's a diffuse or a single or multiple
so
points?
since both the modalities are involved, motor as well as sensory,
So etiology what?
and along with some
Mhm.
paresthesias
Mhm.
as well as the weakness and sensory, it could be a nerve muscle or in the plexus.
So no, that's okay. That's anatomical. What etiology are you giving to this syndrome?
So since the patient we know is diabetic and poorly controlled since last 30 years, it could be a diabetic.
You mean to say diabetic lumbosacral plexopathy or radiculolumbosacral plexopathy? Radiculoplexopathy. What do you
Yes,
want to
sir.
say? You want
Diabetic
to,
lumbosacral plexopathy.
that's
So
Because
Mhm.
yeah, what makes you think there's something in the history which makes you think? See, this case is a little probably from the history you can make out that there are two disease pathologies going on. One 5 to 6 years, which is not really very progressive, which has been there. He says that his chappals used to slip off. Nothing has not worsened in the last 6 years, and once or twice he noticed that the chappal would slip off. But that was sort of static for the last 5 6 years. And now, in the last few months, something has happened, and he has developed this difficulty fairly rapidly. So, if it was the same pathology, you would have expected that would have started getting more and more and more symptoms and weakness. So you are right in saying that there are probably two pathologies. So take each separately. What do you think is the cause of that numbness and chappal slipping off for the last 6 years, which is relatively non-progressive? What do you think might explain that?
that will be the typical glove and stocking type of neuropathy in diabetes.
Okay.
Looking at the pattern, because he had some difficulty in buttoning,
Any
unbuttoning.
other DD for
I'll be back.
distal
I'm in
tingling
class.
numbness in the, because that earlier history was only legs, nothing in the hand, nothing here, just footwear slipping off sometimes over the last 5 to 6 years. So one possibility is the typical long diabetic sensory motor neuropathy. What else could cause this? Very small chance, but what else?
Some form of vasculitis or vasculitic
Okay,
neuropathy.
when will you think of vasculitis as a cause of neuropathy?
But he has no other features. There should be pain prominently.
No, first, my first thing for vasculitis is it a symmetrical illness or is it
It
asymmetrical?
is asymmetrical. It can involve both the upper limbs, lower limbs, and the cranial nerves.
No, no,
Would
no.
vasculitis remain quiet for 6 years without therapy?
No.
So don't say that. You if once you say vasculitis, it tells me that you do not know that vasculitis is typically a mononeuritis multiplex. It will be
So
asymmetric.
since now it is asymmetrical,
But his history also, he didn't say that first one footwear started coming off after a few years, the other foot also happened. No,
So
he just
the
said that
problem
footwear
is
would slip off
the
and it's static. It's
you
not
should take
progress.
you should take more history about slipping of slippers. Is it with awareness, without awareness? Right? Is he started using shoes instead of slippers? So once you have elicited that history, you should probe more. What is that type of slip? Is he feeling the ground as if he's walking on a cotton wool? Is he trying? No. Is there difficulty there more in the night or daytime? Is it sensory ataxia? Is he falling forward while washing his face? You have to probe. You have asked one leading question, but you are not satisfied. You are not getting information. You are given this, but probe. Why this slipping of slippers? If you give importance for 4 5 years, you should have probed more.
So what, Siley, again, if
yes, sir.
somebody says that the footwear, he has difficulty wearing footwear, but footwear doesn't slip off, and if it does slip off, the person understands that it has come off. What are the possibilities you'll think of if it's only difficulty in wearing footwear?
Only he's not able to put his feet in the
Yes,
shoes,
I mean,
in
he
the
has
chappals.
difficulty. He
Yeah,
has
that
difficulty.
he can
May have
have
hands.
apraxia also, sir.
Yeah, so it could be upper motor neuron also.
Yeah.
It could be weakness, which is predominantly motor, but it could be upper motor neuron also. So if somebody says the footwear slips off, but the person understands, it's different. Then what Dr. Gorthi said, is there history that the chappal slips off and he doesn't even know it has slipped off? Then you think of a different set of questions.
And of course, you have to rule out posterior columns and sensory attacks. Yeah,
He
right.
was not, yeah, there was no diurnal variation like in the night.
That is for
So,
neuromuscular junction abnormality. You should not use that term for this. The gait, whether it is more difficult in the nighttime or daytime. Diurnal variation is something different we use for
okay.
neuromuscular junction abnormalities.
Okay, so what are you going to, first of all, localization of that sensory loss or numbness in the feet because of which footwear are slipping off, a relatively static disorder for the last 6 years, symmetrical in both feet. What are you going to think of as the DDs? One is diabetic neuropathy, which you would want to progress, would expect gradually to progress. But okay, we'll take it that he didn't understand it as progress. It's progress very slowly. That is one possibility. Any other possibility?
No, sir, I can't think of anything else which will.
Okay, so 1 minute. Now, what supplies the lower limbs, the sole?
The dermatomes,
Which root?
Dermatomes.
the L5S1.
L5
So
S1.
S1. L5
S1.
is dorsiflexion. So S1. So theoretically, can you say that there could be an S1 root problem which is static? Maybe he's got a disc which is old, maybe whatever there is.
But he never had any radicular pain or
You
anything.
don't have
So
to have. If somebody has neurogenic claudication, you'll not get pain. It will just be a gradual sensory loss. Maybe there might be pain on walking, might be, but might not be. Somebody has written medial and lateral plantar nerves. Can you get both plantar? What happens when the medial plantar nerve is affected bilaterally? What is the symptom? What is it called? Medial plantar nerve getting affected, like you have in the hand. Yes. Somebody's written there. What is that syndrome called?
Starts with T.
tarsal tunnel.
Yes, tarsal tunnel. So what will you find in tarsal tunnel syndrome? What will the patient's history be?
He'll have weakness in inversion of the foot
No.
and
What inverts the foot?
the posterior tibialis.
Yes. So where is the medial plantar nerve?
It is below
Yes. So
in the
there won't be
foot.
weakness. There won't be weakness. What will be the symptom? And then what will be the signs? That is the next way. What will be the symptom?
So will there be a numbness in the
Correct.
medial side of the
In the foot,
sole?
in the
Yeah.
sole.
In
They
the
will not
sole.
say medial or lateral. They'll just say numbness in the sole and burning pain or paresthesia. So any of these, some sensory symptom in the sole. And you have to get the history that there is no symptom on the dorsum of the foot. Otherwise, it becomes a routine neuropathy. It's only on the sole.
Actually, we in this process, is there any looseness in the legs? Does he feel heavy in the legs? Is there any
He
stiffness?
feels loose because he's giving history of like buckling
So
while walking, giving away sensation.
buckling can be because of lengthening reaction in spasticity also. Don't be always under one. It can be have both. Suddenly it gives way, right? So when Golgi tendon organs get stimulated in the tendon, suddenly there will be lengthening reaction. There will be giving away. So don't buckling is not always because of that. So you have to ask specific. Now, why? How do you rule out syringomyelia in this case?
But there is no like.
It's a non-compressive or compressive. It's not a compressive myelopathy, but syringomyelia. How do you exclude? There is an injury to the limb. Why you are not keeping that accidental burning?
Is this a common site for syringomyelia? Where do you get syringomyelia, Sahili?
So it will be cervical.
So what will be the symptom?
So there'll be dissociated sensory loss.
Correct. So,
Upset. So though this burning, if the person had come with painless burn in the upper limbs, yes, you will think of syringomyelia. But in the legs, you are going to think one of a neuropathy or maybe an S1, L5S1 radiculopathy, which is non-progressive. This, whatever that 5-6 years thing is, something he didn't think it's important enough to tell you also.
can
Yes.
bladder stone give rise to pain in the perigenital area?
Yes, sir. It can give rise.
It can give. So it's not only
Because-
that, you have to think of other areas which can, and keeping in the age, could it be anything that is malignancy related? Because you have to think of etiology. You said only fever, loss of a few things, no? No history of
Weight loss I had mentioned, sir.
no hematuria, no
No
hematuria,
hematuria. Yeah.
no hematuria, no to any relation to malignancy. So
There was no
Also-
history of weight loss also.
weight, how much? Say weight loss. What is significant weight loss?
Significant weight loss is if there is unintentional weight loss
Hmm?
of around 10 kgs in last 6 months.
Is it kg or is it percentage?
10% of the body weight.
Right. So
Yes.
it's
Good.
percentage. No?
10%. That's everybody is unique in that answer. I think
Um,
anybody else, sir, shall we ask these boys if they have any questions before we go to the examination?
Yeah. Yes. Why not?
Ask anybody wants to know more details about the case? You can unmute and talk.
Or anybody wants to say anything?
If
Somebody wrote CIDP as a cause of numbness in the legs. Now, what is the natural history of CIDP? Is it a static disease or is it gradually progressive? Dr. Ram
yes,
Tasugari,
somebody
is
has
it
written
progressive or static?
progressive, we said 6 months.
So it's progressive and we do not have that history. The patient has not received any treatment. So you do not think this is CIDP. Unlikely.
So, Sal, if it is myopathy, what type of myopathy at this age you are expecting in this case?
So since he is diabetic,
Hmm.
my first this would be a diabetic amyotrophy.
That is not myopathy, no?
Is it a myopathy? Is diabetic amyotrophy a myopathy?
No,
It's
it is not a myopathy,
it
but
is a
it could be
it could be. It's a radiculoplexopathy,
due
mostly.
to the radiculoplexopathy.
It's
Second thing,
asymmetric,
it would be
mostly.
something related to the hypovitaminosis D induced
You want to say metabolic myopathy,
metabolic,
not
or he was
inflammatory
on
myopathy.
statins also, as I've mentioned in the medication history,
Hmm.
but less likely, but could be one remote possibility.
So you are saying statin-induced myopathy, metabolic myopathy, and diabetic amyotrophy is usually asymmetric and painful condition. Does this person has pain?
No, no pain.
So usually, look, if you read diabetic amyotrophy, it's mostly wasting, pain, wasting, and asymmetric. It can be bilateral, but that's a rare occurrence. Okay. So you read that again and the characteristic features. Anybody else has anything to contribute? I think Dr. Kothari, then I think Sudhir will go on to the
So
presentation.
again, like that's one point I wanted to point out, that you have to start thinking in this patient of two etiologies, two disorders going on. One relatively slow or static for many years, which has caused that numbness. Maybe it is related to that perianal numbness. You may have to think of how to explain that, because your new one, you are saying he's got a myopathy, you can't explain the perianal sensory or numbness. And since you are giving it importance, then you have to keep that as a possibility in your DDs also. Similarly, diabetic amyotrophy, that also will not cause perianal numbness or sensory. So again, your DD or whatever has to explain all the things you are giving importance to. So you
Yes.
have two disorders, one causing that old numbness or something, and now a new disorder relatively rapid with proximal weakness, which may be myopathy, which may be diabetic amyotrophy. Each one has points to for and against. And something maybe perianal numbness which you want to tell us later on why you think it is important.
So one of the
Yes.
residents is asking why not it is inclusion body myositis.
So because inclusion body myositis, you will get some weakness in the finger flexors also in the upper limbs.
Starts typically in the upper limbs.
Yeah.
Quadriceps and the finger flexors.
Yeah, because he said no buckling, that's why he said thighs are involved. That's why I think Apurva got your answer.
And again, there is no pain, nothing like typical of myositis. It's a
Myositis, inclusion body usually will not be painful. It's a very slow process.
You see, pain is not a feature. Even
How
polymyositis.
often do you get pain in polymyositis or dermatomyositis? In what percentage of patients? 1/3, half, 3/4, or all?
And you will be surprised that this is a popular misconception.
How many you think will have? Everybody can answer in the chat.
Yeah, they're
The percentage. Is it 25%, roughly between 25 and 50, 50 to 75, or more than 75?
polymyositis 20% said. It's at least it's 10%. The pain is very less common in polymyositis.
So we try to think that inflammatory disorder means you should get pain. No, it's not very common to get pain in polymyositis.
Yeah, it is not 50. It is less, 10 less.
20, maybe 20 at the most.
Polymyositis is idiopathic polymyositis or dermatomyositis. Polymyositis associated connective tissue disorders. Polymyositis associated with systemic malignancies. So if you're thinking of polymyositis, malignancies are also come into picture at this age.
Yes, and then like Dr. Gorthi said, you have to give that negative history that there's no history of weight loss, no cough, no hemoptysis. If the examiner asks you why you're telling this, you have to tell that since proximal weakness, one of my DDs was dermatomyositis, and therefore I will be asked for anything to suggest malignancy.
Yes.
Let's go to the findings.
Yeah.
Okay, findings here.
Yes. General examination, he was conscious, oriented, cooperative, averagely built and nourished, pulse, BP, RR normal.
I'll just interrupt again. Dr. Gorthi did point out, but that is a very important point, which many people think that there is no such thing as you take the history, you write down the history and everything, and then after that, you do not ask a single question. No, it is not like that. You make a hypothesis. After that hypothesis that you have initially done, you go and examine. But then if the examination shows up something different, you go back and take the history and then refine it. It is not a one-time process. So you can go back and take the history again. Okay, go ahead.
Yes, sir. There was no pallor, cyanosis, clubbing, icterus, lymphadenopathy, rash, knuckle pigmentation, no evidence of any neurocutaneous markers. There was brownish black discoloration, however, below the knees, and there was gangrene over the left foot because of the burn which he had, and all peripheral pulses were present. This was the discoloration below on the shins, and this was the wound he had on the left foot. His CNS examination, higher mental functions were normal. Cranial nerve examination was also normal, except the fundus, which showed some hard exudates. Motor examination, the nutrition.
You should not go away like that. If you have touched this, you have to say whether there is any proliferative retinopathy, background retinopathy. What do you mean by exudate? See, there are so many things which you have to cover in this.
So it was non-proliferative. I could not see any vessels, but there were some hard exudates which I could see.
Okay.
Nutrition, there was wasting, which was seen in the thigh muscles only predominantly, and rest of the muscles were normal. The tone was also flaccid in the thigh, and rest all muscles it was normal. You can see the wasting in the thigh muscles.
It is symmetric.
Yeah. Then the power in the neck muscles and abdominal muscles and upper limbs, it was almost 5/5. And in the lower limb, the hip flexion was a grade 1 bilaterally. Hip extension was grade 2 bilaterally. Lateral rotation and medial rotation was also grade 1. Hip adduction and abduction was, however, grade 4 minus bilaterally. That was slightly better. The knee flexion was 4 minus bilaterally. Knee extension was a grade 2. Ankle dorsiflexion, plantar flexion was grade 4 plus. Foot inversion, eversion, it was 4 plus, 4 plus. Extensor digitorum longus was also 4 plus bilaterally. Flexor digitorum longus 4 plus. EHL 4 plus. Extensor digitorum brevis 4 plus. On examination, further examination, there were no abnormal movements of fasciculation which were seen. Sensory examination, there was reduced pinprick temperature and touch on the lower limbs and the soles, as I've marked in this figure. And there was also loss of pinprick and temperature on the lateral aspect of both the thighs, along with loss of sensations in the perianal area and saddle area. The vibration and position sense was reduced in both the feet, and it was normal in the upper limbs. Cortical sensations were normal, and Romberg's I could not test because he was needing a walker to even stand. The reflexes, superficial reflexes, abdominal and cremasteric were present. Plantars were bilateral flexor. Deep tendon reflexes in the upper limb, biceps, triceps, supinator were normal, and knee and ankle jerks were absent bilaterally. The primitive reflexes were absent. There were no cerebellar signs. Gait, he needed a support of walker.
Was his great big toe amputated?
It was not amputated, sir.
Okay. Okay.
There was a ulcer, gangrene on the lower side.
If it had been amputated, how would
was
you
not
check the
amputated.
plantar?
Yeah, plantar bilateral extension.
How will you check the plantar if the thing was amputated?
Sir, there are other methods like the Gordon's method or something we can use to see by squeezing the calves.
Okay.
But
What else?
no.
When you stroke the lateral aspect of the foot, if the great toe is not there, what else do you see?
The fanning of the other toes.
That is one. What else? Where do you put your left hand?
So below the tensor fascia lata.
Correct. So you have to feel the tensor fascia latae and the hamstrings both.
Both.
And you must palpate them and see which one is contracting when you are doing the plantar. Okay.
Yes.
Yeah. The flexion.
Let me tell you, is it an extensor or not? Okay, go ahead.
There were no cerebellar signs. Peripheral nerves are not enlarged. They were not tender. On the local examination of the spine, there was no kyphosis, scoliosis, or localized swelling or tenderness. No sinus. And I would like to show his gait, video of the gait also. It was a narrow stance, not a broad stance gait. He needed support of the
टर्न करा आणि चाला.
anything, sir, on the examination, or should I go to my diagnosis?
So summarize again. Summarize from after now the history as well as examination.
Sir, after this, my summary would be: this is a relatively rapid onset of proximal weakness in the lower limbs with underlying long-standing love and stocking type of neuropathy, with additional some asymmetrical component of sensory loss. And so the diagnosis I've made on this basis is physiological. It is an element type of paraparesis with additional sensory neuropathy, and the anatomical localization being plexus nerve and the etiology being diabetes.
Okay. So
Myopathy
you have
disappeared.
not told 2-3 things. What is the sensory loss over the lateral aspect of thigh?
Sir, it is in the distribution of the lateral cutaneous nerve.
So that has to come here. It's not written there anywhere.
Sir, I've just mentioned the asymmetrical component for that and the
Niche, final diagnosis. Final diagnosis is underlying sensory neuropathy is your explanation for the numbness in the legs, right? The old one.
yeah.
The proximal weakness
Did
you
you
are
do a
saying
saddle anesthesia checking?
that is another thing you have left out.
Saddle anesthesia checking?
What about that?
So that I've mentioned there was saddle anesthesia in my
There
sensory.
is.
No. But in your final diagnosis, none
So
of
that
your final diagnosis explains the saddle anesthesia.
Where do you see
get
saddle
saddle
anesthesia?
anesthesia, diabetic lumbosacral plexopathy.
we usually don't get, sir, but there will be additional some sacral root which is causing this.
You don't
Saddle
get diabetes.
anesthesia.
You don't get diabetes causing that. Diabetes will affect mainly femoral, like the L2-3 leg thing. So adduction, femoral, proximal hip. You will not get perianal numbness and
So
perianal.
there is some additional thing which is going on in the cauda equina, which is
What
which
is
could
that
be
additional thing?
any degenerative or
Yeah, so that has to come
neoplastic
in
process.
that must come in the final diagnosis that there is something causing a mild. It is a mild thing. No, there's only sensory loss.
Yes.
Got no bladder bowel, so you don't really think of a proper
Yes.
cauda equina syndrome.
Early cauda equina can we get?
Yes.
Sayali,
Yes.
conus medullaris will have predominant bladder bowel disturbances. Cauda equina will rarely have bladder disturbances, but sensory loss, pain, asymmetry, wasting is characteristic. Okay, that is not there here, but still I have my own doubts about your sensory finding in the perianal region, whether we have completely evaluated him or not. But anyway, we'll leave it at this. But your myopathy disappeared. No myopathy mentioned at all. Where is the metabolic myopathy which you thought?
But there was nothing in favor of the myopathy, like
So now tell us why you have ruled in favor of diabetic lumbosacral plexopathy as the cause of the proximal weakness against any muscle disease. What makes you think it is more likely lumbosacral plexopathy and not
so
myopathy?
because of the asymmetry and additional sensory involvement also that I got in the lateral cutaneous area, like the lateral thigh.
No, wait, I don't think you got my question. My question is the proximal weakness in the lower limbs. Initially, you told us in the history that it is either diabetic lumbosacral plexopathy or a myopathy. Now, in your final diagnosis, you have ruled out myopathy. So, what has made you rule out myopathy?
Okay. So, firstly, there's no weakness in the upper limbs, only isolated lower limb weakness in the myopathy.
Yeah.
It is unusual. It will be unusual.
Yes.
Second thing is, along with some sensory components are also I think these have started along with this weakness, like that burning sensation which he had in the genital area. So
Wait.
that involves.
But that is not anyway going in favor of your diabetic lumbosacral plexopathy either. So that is not helping you distinguish between diabetic lumbosacral plexopathy and myopathy. The perianal numbness has nothing to do with diabetes.
Your hip flexion is 2, you said.
Yes, sir.
So, how will you explain?
So hip flexion was 1. Extension
One.
was slightly better. Yeah.
Then how will you explain that? Which neuropathy will cause? You know, CIDP, demyelinating neuropathies have proximal muscle weakness. Okay, but not so much.
And nothing in the upper limbs, so that will be unusual, only in the lower limbs.
So what is in favor of diabetic lumbosacral plexopathy as against myopathy? I'm again asking. One, you told that if you had so much proximal weakness in the lower limbs, you would want some weakness in the upper limbs proximal. That is one point. Second point, wasting. Does wasting tell you something?
So
Does it
so much of wasting will be unusual in a myopathy,
Yeah, right.
and it will be associated with some pseudo hypertrophy.
Not always, but anyway, wasting is not a feature.
Yeah, wasting is not common in, and you will get it in muscular dystrophies, but here you are not thinking of a muscular dystrophy. This guy has a disease which has just started a few months back. So you are not expecting that. So there is wasting, which will could favor the lumbosacral plexopathy. In lumbosacral plexopathy, unlike in a myopathy, you don't need too much time for wasting. It can you may get wasting within months. What about the reflex? Does that favor anything?
The reflexes are completely absent in the lower limbs, but
So
that
knee
can
jerk.
happen in
So
late stages of
ankle
myopathy
jerk
also.
doesn't help you. Ankle jerk, anyway, you think in such a long standing diabetes, it will be absent. But knee jerk is also absent. So that does favor a femoral neuropathy or a lumbosacral plexopathy.
What's the root value of knee jerk?
So L2, 3,
So
4.
naturally, so L23 is also gone. What is L1 localization if you want to test?
So the sensory will be there will be a sensory loss in the
What
inguinal
reflex you
area.
should test? What reflex?
Motor,
What
motor, which muscle
So
does it supply?
L1?
iliopsoas.
No,
Yeah,
no,
yeah.
no.
Hip
L1
flexion.
is what reflex? Anybody?
Somebody wrote.
Cremasteric.
That's it.
Yeah,
That's it.
correct.
That's you have to see.
So cremasteric reflex is the reflex, but muscle power is hip flexion, L1, L2.
L234, L23 iliopectineus is by femoral nerve and by posterior division of upper lumbar plexus. Hello? Yes.
Okay, so to all this, you have final diagnosis is good, except is fine, except you have to add the with bilateral meralgia paresthetica and something causing perianal numbness, which you are sure clinically there is, so you stick to it.
Yes, with additional early cord equina syndrome.
We possibly will not say that there is no pain.
Yes, but no, Dr. Gorthi, the thing is, she has to give an explanation for the perianal sensory loss.
Yes.
So
But
maybe
it's a
some
part of
mild.
lumbosacral plexopathy only will take. If it is asymmetric, it will favor you. So you have to do the saddle testing, anesthesia testing clearly.
Yes, sir.
Right. So suppose if you have done this, then how will you proceed with this? Or what will you do?
Sir, I would like to do the NCV of this patient.
What is the characteristic feature of NCV in this case? In the sensory nerve action potentials, what will you see?
There'll be a significant decrement in the amplitudes.
So snaps may be absent, plexopathy. It's not
Yes.
radiculopathy, but snaps may be absent. And what will happen to CMAPs?
There'll be reduced CMAPs.
Amplitude. How will you analyze CMAP?
Which snaps with sensory first, Dr. Saili? Which sensory will be abnormal?
So the sural and peroneal will be absent.
Peroneal
superficial peroneal, no.
You're talking about possible
Femoral.
So what is the sensory branch of the femoral?
Saphenous.
Saphenous. Very good. And supplies which side of the body? Leg?
The medial side of the leg.
Right. Okay.
Because the guy doesn't have a foot drop, so I'm not really interested in peroneal.
Yes, saphenous now. Right.
Okay, go to motor, CMAP.
How will you describe CMAP in this case? What will be your findings?
So it will be low.
The amplitude, distal latency will be normal or prolonged?
Latencies will be prolonged, amplitudes will be low.
Will be polyphasia? Is it low amplitude? Is it a myopathy? or neurogenic pattern or myopathic pattern?
It will be a neurogenic pattern.
What are the characteristics of neurogenic pattern?
Reduced amplitudes of fibrillations.
That is
With
EMG
polyphase.
finding. EMG. We are still
MCV is amplitude. So when you put in a needle, what will happen? In
So
a wasted muscle like the quadricep, if you put the needle, what do you expect?
fibs, we can see.
Yeah, fibs or
Fibs
positive
and
sharp
positive
waves.
sharp waves. What are giant action potentials?
So giant action potentials are seen in anterior horn cell disorders.
What
How
does
do
it
you define them? What is the giant action? When do you call it giant? Amplitude more than how much?
Sir, I don't know.
you read?
5 millivolts. 5
5
millivolts.
millivolts. Okay. What is myopathic pattern in EMG?
So myopathic pattern there'll be a early recruitment.
What else? What will the amplitude?
So can you explain what is early recruitment?
Early recruitment will be multiple fibers they'll start firing, muscle fibers,
Right.
individual,
Right.
instead of a single unit firing.
So one very simple way is if the patient can, you ask him to contract a little bit, and if you find a single unit firing only, probably the recruitment is normal. If you find right from beginning 2-3 units coming up, that is reduced recruitment. And if you find even when he starts exerting a little more, you still keep getting a single unit, that is what we call single unit firing or reduced recruitment. And then you get that same unit firing a little more frequently, but second unit not getting recruited. What is the meaning of recruitment? When you recruit somebody into the army, you get somebody.
Whenever we start a movement, the number of individual muscle fibers which will come into play.
Yes, so first one motor unit starts firing. Once that motor unit starts firing about 5 times, the second motor unit will start firing along. You recruit one more to help. So that is called recruitment. But in a muscle disease, you will get early recruitment. With slight effort also, you will start initially itself, you will get 2 or 3 units firing.
So what do you understand by interference pattern then?
Yes. What is interference pattern in these patients? And how are the motor units actually? Are they large, polyphasic? Are they short, polyphasic? How are they?
So they are large polyphasic with
In this
fibs.
case,
Muscle disease.
in muscle
In muscle
disease,
disease, what will they be?
They'll be small,
small amplitude.
multiple units firing.
And what interference? Incomplete means what? Total complete interference means what?
So incomplete is
Neurogenic.
this will be complete.
Incomplete is neurogenic. Complete is myopathic. Okay.
Right.
That will be. And then would you like to do a CSF examination in this case?
Yes, I would like to do the CSF.
What for?
What about any imaging? What about any imaging?
Would you
Yeah,
like
imaging will come first, like the MRI of the full study of the lumbosacral area along with the lumbar plexus.
Okay, you have done this. Root enhancement is seen. Lumbar. That's what somebody Ganesh is saying.
CSF would not help much except from there'll be slightly raised proteins. Would not help much.
Okay.
Yeah, but CSF often helps by showing what is not. So if you suddenly find a lot of cells or you find very high protein, you are going to think of something different. If you find a little bit, maybe 60-70 protein, you are going to think of a diabetic neuropathy anyway.
All right.
Yes.
What about, would you want CPK or you have ruled it out totally?
So I would like to do CPK because we can just rule out the other inflammatory causes.
Very good. Okay, finally you have done. How will you treat this?
So the main line of treatment would be initially they say that it is a mini vasculitis which goes on, microvasculitis. The etiology is that. So people have used steroids for around 12 weeks, weekly one injection, and that has shown improvement, along with strict control of glucose.
Okay. Do you have any role for IVIG?
There's no role of IVIG in this.
So people have, just as people have tried steroids, people have tried IVIG also. Both steroid as well as IVIG is a little experimental, and I would try it only in the initial stage. If the person comes within the first few weeks, there's a lot of pain and weakness. This guy is going on for 3-4 months. I would not really bother about either steroid or IVIG. The problem with steroid is you're going to worsen his sugar, and you want the sugar to get under control for improvement.
I think.
If you found enhancement on the MRI of the plexus, then maybe I would push more towards giving either steroid or IVIG. But if there's no enhancement, probably not useful. What do you think, Dr. Gorthi?
Yeah, I think you are correct. It's the same thing we also follow. Enhancement will guide the further treatment. But diabetic control is very important.
So this is very often you will find this sort of diabetic lumbosacral plexopathy. This is one of the diabetic neuropathies which is potentially improvable or reversible, and often it happens with a period of very poor control of diabetes. It is often associated with weight loss, and like diabetic, is there any other diabetic neuropathy which happens like this, when there is very high sugar, when there is weight loss, and which improves with time? Which other one?
Bruns-Garland.
Which are the diabetic neuropathies which improve?
So Bruns-Garland is one of them. Which,
What is that? Sorry.
What is Bruns-Garland?
so that also improves with.
What is Bruns-Garland? I don't know.
What is
So
that?
it is similar to this like lumbosacral plexopathy only, but I don't know what is the pathological difference in.
It's the same thing, no? I mean, it's a name. Somebody wants to give his name to that thing, but it's lumbosacral plexopathy. That's what we're saying here. What else? What about third nerve palsy, sixth nerve palsy?
Yes, isolated cranial nerve palsy.
They will improve. What about somebody getting radiculopathy in the thoracic or abdominal area?
Truncal neuropathy.
Truncal radiculoneuropathy. That also improves, and that also is associated with sudden increased blood sugar.
So apart from this, I would like you to understand that lumbosacral plexopathy, there are only two diagnoses apart from diabetes. Either it is trauma or cancer. So plexopathies, the diagnosis, the differential diagnosis only important two. Apart from diabetes, either you rule out cancer or it could be trauma. So we have to keep in this age group cancer always in consideration and take history accordingly.
And of course, radiation for cancer.
Once, of course, it is there, then it. Okay,
sometimes it becomes difficult when you have a person you have irradiated and they come with a plexopathy. Is it radiation plexopathy or is it malignancy? Is there any point which favors one?
Yes, somebody can.
Radiation will be a precipitate, will be after the radiation history. There should be some history of taking radiation.
Cancer can.
Yeah, there is. No, somebody has a cancer, he's radiated, and now he comes with a plexopathy. What do you think it is the cancer which is again coming up, or is it radiation? How will you, what favors it?
Pain. Sir.
Pain. Yeah, very good. Excellent.
Very good.
Pain is a more characteristic of.
And like somebody said, myokemia. That is also correct. Radiation, EMG wise, it will often show myokemia, but pain is very important.
I think, Sudhir, we had a very good case discussion. Shall we call it a day?
Yeah, I think, Saili, you want to show the MRI?
Yeah.
Yes, sir.
Yeah, did you do that? Actually, I didn't know this. No, sure.
There's something funny.
I want to discuss some things on the differential diagnosis.
Okay, come. Okay, carry on.
I've put mononeuritis multiplex. and proximal myopathy due to hypovitaminosis D statin with additional diabetic neuropathy with underlying cauda equina syndrome due to some degenerative and neoplastic cause. So that was
And
my DD.
statins also cause neuropathy. You should understand this. Okay. You refer.
But then, Sally, proximal myopathy due to hypovitaminosis D, what are the reflexes, knee jerk normally?
It will
Preserved.
be preserved, yeah.
Preserve often brisk actually. So I wouldn't agree with this differential diagnosis, nor will I agree with mononeuritis multiplex, because if you say mononeuritis multiplex, it is affecting how many nerves? It is affecting the femoral nerve, it is affecting the hip flexion nerve, the nerve to iliacus, it is affecting the nerve adductor. What is that nerve? The nerve which
Obturator.
Obturator.
Obturator nerve, and it is affecting both bilaterally and not a single nerve in the upper limb. So it's very unusual for mononeuritis multiplex to happen this way. So I would not put that in the DD.
So then what would be the DDs?
No DD. No DD. You have already made a diagnosis.
Whenever you got a lumbosacral plexopathy, it will be DDs are cancer, radiation, trauma, and diabetes. So yours is diabetes first.
Yes.
Yeah, you've already made the. See, if you now again say mononeuritis multiplex, you are negating your whole logic thinking process. If you say
vasculitis again,
myopathy, it will say then again I'm going to array. You don't know myopathy may reflex will be present. So you can't say that.
We need not mention DDs then.
No, you don't have to give.
See, you said vasculitis. Now, then Dr. Sudhir asked you what are the characteristics of vasculitis neuropathy, painful, asymmetric. Then what are all the painful neuropathies? Then question comes, your Viva will go in some other direction.
Yes.
Show what else you want.
Show the MRI and let's call it a day.
So
these are the blood investigations.
Microalbuminuria is there?
Oh yeah, it was there. Microalbumin was raised.
Creatinine is also okay, normal.
1.2. And PP was 255.
HbA1c? No idea.
6.8 it was recent, which was done in
it had been very high. It was 300, 400 during that November, December period.
Earlier it was 7.5 and now it was 6.8.
Will you explain the ESR?
So ESR we are not able to explain in this.
Maybe the foot is infected.
Yeah, the foot gangrene over the foot.
Okay, all right. Show me what is
this was the MRI, cervical spine, and you can see the dorsolumbar.
Would you want anything more in the MRI? You are not seeing anything in the MRI, but you have to explain. You are not seeing a disc. So if your perianal numbness is definite, what more will you want?
Is there cervical myelomalacia around C4, C6?
So there's a incidental searings which is there.
Very small. That's a gliotic area, cervical, but not causing any myelopathy signs or no symptoms.
Okay.
The MRI of the spine lumbar also is normal. So would you want anything? Eggshell cuts also, Dr. Dasugiri, have been done which were normal. So now what? Either you say that you are imagining that perianal numbness, but Dr. Sahili says it is definite. So what more? Pons hyperintensity? No, that Pons may there is either chronic ischemic lesion or many people have asymptomatic central pontine myelinolysis. Yes, Dr. Apurva Reddy has asked for a contrast MRI. So you are very right. You should do a contrast MRI, and we did one. Show that.
Yes.
What is there in this?
So this is a coronal section. You can see that white hyperintensity here.
Yeah.
There was a small possible, we don't know what it is, but probable neurofibroma which is there affecting these, S234, that region. So that perianal numbness was due to this sort of probably static old, very small neurofibroma, which is not causing anything more except that perianal sensory loss. So if the guy gets bladder or anything later on, we'll see. But as of now, we thought we'll leave it alone. We'll just ask him to get the sugar under control, and we expect it to improve in the next 3-4 months. We'll give a follow-up what happens to him afterwards.
Good. The puzzle is solved. Right.
So this was the NCV.
Okay.
Actually, the MRI, let me be frank, it was done for the wrong reasons. Because when I saw him, I thought he's got that numbness up to L2, but it was neuralgia paralysis. I thought both lower limbs up to here. Plus, I didn't check the medial thigh.
Okay.
So he had up to. So I thought there is something causing quad-iconic syndrome right up to L2, but sparing L1. I told them, look very carefully. They said MRI now. I said, then no, do a contrast. There's something affecting the lumbosacral spine there. I hadn't checked his perianal sensations at that time.
Oh,
Anyway, but we found it. So
right. That's very nice.
okay, thank you. Any questions anybody has?
Sudhir, next clinic when?
Next, Kabhi, just now I'm a little free, so we can do it. If you have a case next Wednesday or today's what? Friday. Next Friday or then.
We'll keep it on next Friday. Then we'll see.
Keep it because then again I am going off for some time. So
next Friday.
Okay.
We'll continue this forum, and one of us will be there, and we'll ask others also if they want.
Yeah.
So I think it's useful. Many students have attended. We'll give chance to others to also come forward.
Yeah, next time whoever is, you can have someone present from your institute.
Yeah, we'll give chance to other hospitals also to come and join. Thanks, Sudhir. Okay, then.
Okay, thank you. Good night. Good night, everybody. Bye.
Thank you, sir.